Well, thank you for having me, Roberto, and Jerry as well. It's a pleasure to give this talk as well as the other talks in the course. Hopefully this will be more than you were expecting. I do have some acknowledgments of cardiac sonographers, our fellows, and my colleagues at Temple, as well as Dr. Marty Keene and Susan Wiggers at Temple. I don't have any financial disclosures. So the normal echocardiogram, so why do we need to review this? Why did we start with this? Really, the overwhelming reason is that we need to recognize pathology when it exists. And if you are interpreting normal structures as pathologic, then you're not doing any service to your patients. And in terms of the exam, the goal for the normal echocardiogram and testing it is to standardize image acquisition. So can you recognize the standard protocols? Can you optimize your images? Can you identify simple anatomy? Can you quantify chamber volumes, dimensions? Can you identify some of the less known normal cardiac structures? Like I said, recognize pathology when it exists. And then also do them appropriately, do echocardiograms appropriately and by our guidelines with appropriate use criteria in mind, doing them safely when we're talking about transesophageal echo in terms of indications, as well as contraindications to these studies. These are all testable ASC exam type of topics that you should keep in mind when you think about the normal exam. So two key documents that I'd like you to be aware of for the exam. The first is, like I mentioned, the appropriate use criteria for echocardiography. And the importance of this document is that they can ask you post-clinical scenarios and ask inappropriate or appropriate. The uncertain aren't going to be tested, as you can imagine. But for example, in this list, evaluating a patient with a new cardiac murmur, and that might be appropriate as a new study, but in serial follow-up without any clinical change, it may be inappropriate. Or even more pertinent maybe to your clinical practice, at the bottom of these appropriateness criteria, of which I've just provided a sample, a patient with valvular stenosis and reevaluating mild valvular stenosis within 3 years is considered inappropriate without any clinical significant change. So it's an important document to review and certainly review the common appropriate and inappropriate criteria. The other is the TE guideline, excellent document by Dr. Hahn and colleagues, Dr. Lang as well. Really standardizes the views by transesophageal echo, gives you very standardized views with the standard cardiac anatomy, including moving video clips, as well as the indications, contraindications, how you prep patients, what are the important medication, anesthesia issues, what are absolute relative contraindications as I've listed here, just as a sample of how important some of the key figures out of this document are. So that's why I really emphasize these two documents when we talk about the normal echocardiogram. It's certainly something you should review in detail prior to the exam. So let's talk about transthoracic echocardiography. And it may be a different type of style that you're used to here, but I'm going to start with the basic of basic, right? The parasternal long axis view. And sometimes the views aren't just the cardiac structures. It's appreciating the extracardiac structures. It's appreciating the view of the cardiac structures that might suggest you're off axis. So in this case, on axis parasternal long axis, you can see the long axis of the ventricle is nearly 45 degrees to horizontal. The aortic valve is nearly on top of the mitral valve, and the RVOT is displayed at the top of the image. This on-axis image, you can even see the coronary sinus at the base. You notice that the depth is adjusted such that you see the artifact as it streams off the pericardium beyond the heart. But usually we typically require or acquire a different image initially because depth matters. So although we can take that initial view, and we use that often clinically to get a quick look at patients, if you look with depth, you can appreciate the depth of artifacts. You can also appreciate pathologies which exist at further ultrasound depths, like this left pleural effusion noted on the left part of the slide. And it's sort of coincidence because Dennis reviewed an exam question that highlighted a left pleural effusion, but certainly not inappropriate for showing up on your exam. And also note when I comment on depth and showing pleural effusion that there are right pleural effusions that we sometimes pick up by echocardiography. This is not the most common way to pick it up. Obviously now you're seeing the right pleural effusion on the other side of the artifact created by the spine, but I assure you that, from a subcostal view that this patient did indeed have right pleural effusion. But so you might think parasternal long axis is pretty boring, but you got to appreciate that the depth of your imaging matters as well. Also, positioning. No one echocardiogram is the same as the other. The image that I showed you initially is the on-axis image is in the upper left, and the image down one interspace is on the right. So you can appreciate now the long axis of the ventricle is much more vertical. The aortic valve and the mitral valve are no longer stacked on top of each other, and we're no longer really viewing the RVOT. So this is an off-axis image, and this is certainly appropriate for you to recognize on an exam as off-axis, and certainly suggest to move up an interspace or down an interspace depending on the image. So if I give you the opposite, so I've done these with the help of our sonographers and my own imaging to demonstrate in the same patient. If you imaged from the on-axis image and you went up an interspace, what type of image would you be looking at? You'd be looking at the ascending aorta. Sometimes it's pertinent, but it's not an appropriate parasternal long axis view. Even if you tweaked it to get the ventricle in view and you can somewhat see the LV function, it's not a standardized view. So it's important to recognize how as you move the probe, you can acquire different images that are all part of the normal echo, but represent different cardiac structures. So on the topic of off-axis imaging, remember that a lot of what we do in echocardiography is quantitative, and measurements are important. And Dr. Keen's going to follow my talk with a talk on a number of cardiac chambers, and then Dr. Lang with chamber quantification. And this is a very key point. If you have off-axis images, you're making off-axis measurements, and you're not doing your patient service or by making inappropriate measurements. And you can see the red lines identified here, where in that image where the LV long axis is too vertical, we're making an inappropriate measurement of the LV inner dimension. And even if you think, oh well, I'll make it, I'll do X plane, and that's the image on the right, and I'll show the short X and I'll make the measurement there. You're really just taking an off-axis image and generating another one, and then making an inappropriate measurement. So it's important to make the correct 2D guided measurements. And I think we'll belabor that point through the course. So on-axis measurements in the same patient. Now we're measuring the LV cavity at the leaflet tips, and appropriate measurements and appropriate axis in terms of the parasternal long axis. So why else does on-axis imaging matter? Well, because we've developed this universal language to describe the myocardial segments in the heart, so that when Dr. Lashner talks to Dr. Peters about some wall motion abnormality, they're talking about the same thing, and they're talking about the same finding. So in this case, the on-axis parasternal long, as all of you know, I'm belaboring the point, but it's something that you use on a day-to-day basis. With the appropriate image, you're identifying the appropriate myocardial segments and describing the heart and its segments in a universal language. And I've shown an apical 3 labeling of the segments, but this is a parasternal long axis. Short axis not to be neglected, right? Short axis imaging, whether you acquire it from the parasternal acoustic window or from the subcostal acoustic window, has equally necessary requirements to be on axis, and so that you're looking at the same myocardial segments. In this case, we're in the mid cavity, and we're looking at the anterior anteroseptal, infroseptal, inferior infralateral, and anterolateral myocardial segments in the mid cavity. Right there, you've knocked out 6 segments of the 17. And you noted that you can image both of those, or all of those segments from 2 different projections. Sort of a double check if you had artifact or if you had inability to visualize an endocardial border. And now, of course, the apical four-chamber. If you're looking for a quintessential view, if it wasn't the parasternal long axis, I guess this one would qualify. And I'll probably make this more boring than you ever thought a four-chamber could be. But I think that a lot of the extracardiac findings on a four-chamber, as well as the cardiac findings, can tell you a lot about whether you're doing on-axis imaging. And I'm going to show that to you. So this, I think we all would accept as a reasonable four-chamber image with some limitation at the apex there. Probably a little bit of bang artifact from the ultrasound probe and some not completely normal echo, right? Some lipomatous hypertrophy. It's tough to find normal echoes. So this is a four-chamber view. And if you went and imaged that same four-chamber view in that same acoustic window, but tilted the tail of the probe down, so now your transducer's pointed more superior-anterior, then what do you develop? You develop what some call five-chamber view, but you're bringing the aortic valve into view here. Right? You're no longer looking at those same myocardial segments that we normally see in a four-chamber view. And now you're looking at the superior-anterior projection of the heart in the four-chamber. And closer to that apical long axis view that I showed you, that I showed next to the parasternal lung. And so what can we see within the heart that identifies structures that we would know that? Well, you can see the aortic valve. That definitely shouldn't be seen in four-chamber view. But let's look beyond that. Let's look for other superior structures. How about the Coumadin ridge? Everyone sees the Coumadin ridge there in the left atrium? Coumadin ridge, the upper pulmonary vein, left upper pulmonary veins partially visualized there. The os of the left atrial appendage is even seen. These are high anterolateral structures. These are other hints. How about in the right atrium? We're starting to see structures that aren't the body of the right atrium, but rather the SVC as it enters the right atrium, and maybe some hints at a Crista Terminalis. So we're obviously angled superiorly. Look outside of what your eye is immediately drawn to notice that the image is off axis, and this can be corrected by bringing the tail back up and bringing it back onto a four-chamber view. How about if the converse was true? The tail was up, you're looking too inferiorly in the heart. So what I did in this patient is I angled the probe with the tail up, so now I'm imaging very basal. And now you can appreciate in the image here, as I compare it to the standard apical four-chamber, you can appreciate coronary sinus. You're no longer looking at the as much of the superior portion of the heart, but you can see things like coronary sinus. You can even see the IVC as it enters the RA, and you've completely obliterated the LA because you're looking down at the left AV groove. You're looking at left AV groove type structures, including the great cardiac vein. So it's just taking account of all the anatomy that's present in your image and letting it tell you what type of image you have. These you may be more and more accustomed to, recognizing that your apical four-chamber might be off axis. The LV apex should underlie your ultrasound probe, and you can see in the image on the left, we're off axis. The RV apex is snuck in there above the LV apex, and it changes your view of the LV and the LV size. And so if we're going to make standardized comparisons between studies, we need to make sure that we stay on axis. And of course, there are the standard 17-segment mono labels for myocardial segments in the four-chamber that are appropriate. And it's not beyond the scope of the exam to point at with arrows to identify myocardial segments, because this is the universal language that we communicate with. So we're talking about normal. What about normal? Well, you're not sure it's normal. So what's the case on the left? The case on the left, we think it might be normal, but the issue is apical foreshortening. And so this doesn't really give you a diagnostic look at the mid to apical LV. Or how about the case on the right? So what's the issue there? The issue is there's no endocardial definition. And so you don't really know if it's normal. You could have guessed before you even did the study. That's probably a better pretest likelihood of being correct. So how do we fix that? Contrast. So there's going to be a separate talk on contrast. and the application of it, but I feel like it has an appropriate role in the normal echocardiogram because it restores the diagnostic accuracy of non-diagnostic studies. So it improves endocardial border definition by LV opacification. It helps to eliminate foreshortening because you're able to image the blood pool and bring your images back on axis, as well as evaluate for mural thrombi, and that's not all part of a normal echo. But really, the essence of it is that you're restoring the diagnostic quality of the study by using contrast. So I try to, after every so many slides, bring you back to the exam focus. So how on the exam are they going to test you on the things we just looked at? They're going to ask you, how do you fix this image? So you got to recognize off-axis views. You got to recognize that they might be imaging from the wrong interspace, or recognize that they're foreshortening a cardiac structure that might change your assessment of its function or pathology, or even test you on the contrast use or optimization to restore diagnostic accuracy in studies. Anatomical identification, these are easy pitches that you can knock out of the park, knowing your cardiac anatomy and echoes. And myocardial segment, another probably even easier pitch to knock out of the park. And then extracardiac findings, appreciating the non-cardiac structures you're imaging. And that's why I sort of went into a little bit of detail in the pleural effusion and the spine that were visible in that image. And then as we go through the course, you're going to get an appreciation for the different types of artifacts that are present and what they look like in imaging. So the normal echo is not all about 3-chamber, 4-chamber views, parasternal long axis views, 2D imaging, but it's also about what's the normal physics of the 2D images that you acquire. So if we image with fundamental imaging, we're imaging with some fundamental frequency, insonating at that frequency, we're going to listen at that same frequency. And in the case of tissue and noise that is in our image, they have different responses to that frequency of imaging. And the ratio of the returned backscatter, that's what we're looking at on the screen, is what we represent as signal to noise. But almost none of us look at pure fundamental imaging anymore. Now we use tissue harmonic imaging, which is insonating at that same frequency, but listening at the second harmonic, because our signal to noise, or the ratio of the tissue signal to the noise signal, is enhanced there. And the nonlinear distortion of the acoustic signal in the tissue generates these harmonics that we image. So noise and artifacts, they don't generate any harmonic. So they drop in terms of their intensity and allow us to enhance the signal. Tissue harmonic imaging clearly takes advantage of this increased signal to noise, and it's an important concept that we use on a daily basis. And many of us probably don't even recognize that we're using it. So I'll give you an example. On the left side is a fundamental image, 4-chamber view. Blood pool's not so nulled there, right? Not such great endocardial border definition. A little too much noise in the LV blood pool. And so that's insonating at 4 megahertz, listening at 4 megahertz, I'm guessing at this point. And then on the right, what I did was I turned tissue harmonics back on. And so I listened at the second harmonic, and you can see we're able to null the blood pool, improve endocardial border definition. And in some people, some may note that the appearance of 2D structures seem a little bit thicker. They seem a little bit brighter. That's the signal to noise ratio that's increased. And so you'll notice that as you do clinical imaging, you're going to notice that tissue harmonics makes things thick. Remember that mitral valve that's thick, but it's not thick? You remember the aortic leaflets that just don't seem quite normal? Think back, maybe it's tissue harmonic imaging that may be what you're perceiving, and there is actually not pathology present. Other examples, bubbles have harmonics too. We'll talk about that in another talk, but you can see an image on a patient I did with contrast imaging using harmonics, so listening at 2.6, imaging at 1.3, compared to just using fundamental imaging on the right-hand side when we're imaging with bubble contrast for LV opacification. So it has an impact there. Not to mention all the other things. Bring the focus down to the mitral valve. Adjust the TGC so you have an appropriate blood pool. You can see there's not any significant severe attenuation at the apex. But you know what? It's still a normal echo. Other things you should appreciate that are important when you read a normal echo, when you interpret one. when you take the ASE exam. Optimal 2D images are when the ultrasound beam is perpendicular to structures. Optimal Doppler imaging is when they're parallel to flow. So both of those should be taken into account when you do imaging. And the apical views are pretty much the views that allow for any alignment with the cardiac flows. So generally any valve assessments are done from that apical acoustic window. So these are just very basic. We'll go over these things again later in the course, but just to recognize them as part of a normal study. Color Doppler, still a pulse wave modality, can't resolve high velocities. You can use different types of maps to define jets, the direction of jets, and the turbulence if it's present. Pulse wave Doppler is more range specific. You're setting the gate in a specific location, but it'll be subject to aliasing at high velocities, just like color flow Doppler, because they're both in the same technique. They're both pulse Doppler. And then continuous wave Doppler able to resolve higher velocities, and it's really range ambiguous, but we mostly use that in our mitral and aortic valves. So why did I tell you all this? Well, because I want to give you tips in looking at the normal echo on the exam. And when you look at color flow Doppler, whether you're taking the ASE exam or a vascular exam, you got to pay attention to the baseline. So where's the baseline? It's that black bar in the center of the color map. You got to make note of the Nyquist limit. In this case, 0.66. And you got to note if that's varied, or if it's too high or too low. And then also note that color scales can vary. This is some arbitrarily applied color scale. They could flip that color scale, or they could add a variance map to look for turbulent jets. These are things that you should be aware of, because you're going to see a vast variety of images, and you should be aware of the physics of and the normalcy of studies. And when you do color Doppler, you want to optimize the size of that sector. You can see in this example, the sector was optimized for the aortic valve, and then the 2D was blacked out as well to improve the frame rate. So these are all components of normal exams. Other Doppler optimization that's fair game for the exam. You can see that this is LVOT sampling and spectral Doppler of a pulse wave type on the top, and then to the right, a very large scale that truncates that Doppler. So on the left it's aliased, on the right it's too large of a scale. So the optimal scale there is to allow the spectral profile to fill about 2/3 of the screen. So you had to decrease the scale to optimize it here, because you want to make an accurate measurement, although it's normal, an accurate measurement of Doppler. How about this case? This case, we didn't have to adjust the scale. In this case, we could just move the baseline, just like moving that black area in the Nyquist, the black area in that color flow map. We move the baseline up to prevent the aliasing of the LVOT sample. And so by a baseline adjustment, you can see that you brought your image back into view, fills about 2/3 of the scale, and you can make an appropriate measurement. Don't have a large scale and a tiny signal and try to make an accurate measurement. Just like PISA, you should zoom in. So in the exam, these things can be touched upon by talking about effects of harmonic imaging. How does it affect your images? Appropriate indications for contrast, contrast physics and optimization, which we'll talk about later. Types of Doppler and technical limitations, but also spectrals, and I think these are more important, spectral Doppler signal optimization, as well as color flow optimization. These are all considered part of the normal echo exam. So we talked a lot about transthoracic, we talked a lot about some of the basic normal physics and Doppler techniques. Also included in this talk are some normal transesophageal studies, and we all do transesophageal echo for different reasons, but one of the major powers of transesophageal echo is its higher resolution, higher frequency imaging, and its multi-plane capability. This is an example of that, looking at the mitral valve in a long axis aortic view, but showing the number of views through the mitral valve that can be obtained by TEE to look at the different scallops. I think this you're very familiar with, so I won't go through each of the details, but it shows you an example of some of the figures and images that are available in our guidelines from 2013 now. 3D mitral valve, this is considered part of the normal exam. This is part of the normal TE. And so you need to appreciate the 3D anatomy of the mitral valve. the structures that surround the mitral valve and how they appear on 3D, as well as the scallops, the commissures, the papillary muscles, the chordal structures, as well as any pathologies, obviously. But in this example, just remember that you shouldn't be surprised to see a 3D image show up on your exam. How about the aortic valve? So these are some more standard images from our guidelines, looking at the aortic valve on a TE. Now the left atrium is at the top of the sector, right? You can see the omniplane angle always reported. That's always the giveaway, unless they crop that out. The RV, which is the most anterior structure in the heart, is the furthest away. And then you can see the tricuspid and the pulmonic valves. So you can look at because of the multiplane nature of TE, you can look at a short axis and long axis with fairly few limitations in terms of acoustic artifact. I hope that projects appropriately, but you could be presented with a 3D image of the aortic valve as well, asking things like cusps and coronaries and pathologic findings as well, and asking what cusp they might be associated with. Many of us do TEs and focus on the left atrial appendage, so appendage views are common. You can see in the upper left here, we're looking at a long axis view of the appendage, if you will, a new term, and a biplane image that allows us to see the pecten A muscles and no evidence of thrombus, which is the most common reason we will do these. But then also you can see a view of the appendage in the bottom right that not only shows the appendage, but shows the pulmonary arterial flow. It shows transverse sinus. It shows the circumflex coronary, as of course is just under the appendage, as well as bits of the mitral valve. So it's important to appreciate the structures that are right nearby. Bi-Caval view is a common view. Here you can see the SVC entering the right atrium from the right. You can see the Crista Terminalis is pretty prominent there, that fibromuscular ridge, just as the SVC empties into the RA. You can see the intraatrial septum, and then at the 9 o'clock position, you can see the IVC as it enters from the liver. So that's the suprahepatic IVC. And then up at 11 o'clock, 10, 11 o'clock is the os of the coronary sinus as it wraps the left AV groove, because that's the left atrium at the top of the image. So these are standard TE images in the standard anatomy. And one common image to apparently show up on the exam is the transgastric views, and these are all in the guidelines as well. But important because you're getting, again, a short axis view of the heart, the papillary muscles and their configuration, as well as a long axis view, and knowing which wall you're looking at. And knowing that the posterior wall is at the top of the transgastric image and the anterior wall is at the bottom of the image to help provide you some sort of framework to understand it. But TE is not heavily tested. I'm not going to spend a lot of time on it. But what is tested is the appropriate use, the indications and the contraindications for performing a TE as they're outlined in the guidelines, anatomical definition or identification as they relate to cardiac structures on TE, standard 3D views of mitral and aortic. This is really the standard now. And then correlative anatomic imaging with transthoracics, so identifying cardiac structures. So I mentioned cardiac structures. Let's just run through a bunch of normal anatomic structures that we're able to see by echo. And then hopefully we can sort of wrap things up. So persistent venous valves, this is common. It's not uncommon for you to see a picture of a Chiari Network or a Eustachian valve on the exam, because this is a finding that's readily visible and should be known to be non-pathologic. So Chiari, it's not really known what its function is. It's not present in every patient. It's really a net-like structure, and it's highly mobile. That's usually how we identify it. And it usually arises in the vicinity of the IVC and is attached to the septum. It's not attached to the septum, rather. The Eustachian valve, it's more intended in fetal flow, where it's directing flow across the fossa vellus, and it's present in every fetus, and this a ridge of tissue that we often image on echo imaging, and it's rarely mobile. Eustachian ridge is rarely mobile, and it arises from the IVC and runs to the fossa vellus. So I'll show you some examples of Eustachian valves. So these are two Eustachian valves in subcostal projection. You can see the intrahepatic IVC, then the suprahepatic IVC, and then that structure That is the Eustachian valve. And you can see how in the bottom right image, you can see how it could direct flow just across that atrial septum here in that subcostal view. Chiaris come in all sorts of varieties. I chose 3 of them here to show you that they can rear their heads in all sorts of projections. So in the RV inflow view on the left, you can see a Chiari. You see the IVC entering the body of the RA, and you can see the Chiari highly mobile. In the apical 4, you can see something flickering around in the right atrium. And then even in the parasternal short axis on the right, you can see the mobile Chiari network. So sometimes, or in many cases, these venous valves exist together, and that's the example here. You see a prominent Eustachian ridge, and you see a prominent Chiari network. These are normal findings. These aren't pathologic. But on that topic, one that's often not talked about and is often worked up, I do multimodality imaging, so many times we'll do advanced imaging to evaluate cardiac masses, is a normal structure like the Crista Terminalis. So it's often confused for a right atrial mass, but in fact it's just a smooth myocardial ridge that's between the RA and the SVC, right at that junction, and it's along the posteral lateral right atrial wall. And you can see it highlighted by that blue arrow there. This was a case, an example of one that I imaged. There was a prominent right atrial mass called on Transthoracic echocardiography, and it's right in the region there as the SVC enters the right atrium. And on CT, you can see the blue arrows pointing at this Crista Terminalis. That's probably the largest one I've seen, but in fact is not a pathologic mass. So be wary of things like that. I think somebody in this room probably saw it on his exam before. Moderator band. It's a muscular structure that's more likely related to maintain geometry of the RV rather than more functional, but also has electrophysiologic issues associated. But it's, again, a normal structure, and I won't spend much time on this because I think everybody in this room has seen a moderator band. The coronary sinus, always important to appreciate potential reasons for a dilated coronary sinus. Usually not well seen, but like in the parasternal lung I showed you, coronary sinus is present there in the left AV groove. And I showed you an RV inflow view on the right-hand side with the blue arrow pointing at the os there where the Thebesian valve is that enters the coronary sinus, just at the level of the tricuspid annulus. This is all normal and normal in appearance. Pericardial sinuses find their way as well. You know, those pesky sinuses, there's 2, the oblique and the transverse sinus. It's rare. These recesses behind the heart, it's rare to see the oblique sinus. That's more at the level of the pulmonary veins and below. They are not associated with the great vessels, the oblique sinus. That's in that lower area between the pulmonary veins. And then the transverse sinus, anytime you're looking at a potential space that's not the pericardial space, but is a space related to the great vessels, you're looking likely at the transverse sinus. And I pointed that out when we looked at an image of the left atrial appendage. And there was that space that existed between it and the PA, and that's the transverse sinus. Again, this is that same image I highlighted with the blue arrow there, just pointing out transverse sinus. So be aware of your pericardial recesses. Well, not your own personal ones, but the ones you'll see on the exam. So here's some other views that are normal subcostal short axis views. So not every study can be done transthoracic in those acoustic windows. Some are done subcostal, and we can save studies from the subcostal window. But realize that we can get a nice short axis view of the aortic valve from the subcostal window, see the right atrium, the RV, the tricuspid and pulmonary valves, as well as the PA bifurcation, even on a subcostal view. And just remember now, the heart, the image is rotated. So you've got to use the structures outside of what you're evaluating to decide what you're looking at. So how do I know that's the right coronary cusp and the non and the left? Well, the non-cusp is associated with the intraatrial septum. That's easy. But then the right is associated with an anterior structure. It's the anterior sinus of Valsalva, like the RV. And so the RV wraps the right sinus of Valsalva. And then the left, with that L hiding in the bright white signal, is associated with the left heart, and your left main pops out right there between the aortic root and the pulmonary artery. So talking about coronary arteries, it's not unreasonable to identify them. They're normal structures. They show up on echoes. And in our important parts of our clinical exams on young patients, In this case, you can see both coronary arteries with the right coronary artery visualized at the 12 o'clock position in the moving clip, and then at the 3 o'clock position is the left main, and that stored still frames there just to point them out. They can look, their appearance can be varied, and the anomalous course can be even more difficult to assess. But if you're able to identify orthotopic origin of the coronaries, this can help you in patients and the exam. Here's a parasternal long axis. Not uncommon to see the right coronary pop off of the anterior sinus there in the parasternal long axis. That's easily identified. In this case, the left main ostium is easily visible, but probably because we're a little bit off axis on this aortic valve, where we're only seeing the right and the non-cusp move. And we're deeper into the sinus of Valsalva, so we can see the origin of the left main. They like the idea of correlative imaging between our modalities. So keep an eye out for studies where you can identify coronary arteries on TE as well. In this case, you can see the left main originating from the left coronary sinus, and you can see it bifurcating into likely a circumflex and a LAD vessel. So in this case, you have to use your anatomical sense on what kind of study you're looking at. It's a TE. What structure and coronary sinuses originate from. That's the left coronary sinus. And then what vessel we're pointing at. This vessel courses anteriorly after the left main bifurcates. So it wouldn't be unreasonable for them to ask you whether this is an LAD or circumflex coronary you identified on TE. And in this case, it would be the LAD because it's coursing anteriorly or away from your TE probe. Papillary muscles, we talked about it earlier, the posteromedial and anterolateral paps. And I highlighted that the posterior wall of the LV is at the top of your transgastric image, so don't get fooled by that if they happen to show you that image. But again, it just shows you how good a nice transgastric image is at looking at the subvalvular structures of the mitral valve, but in this case are normal. Pulmonary veins, they won't ask you to identify likely specific pulmonary veins, but know that pulmonary veins as they return to the left atrium can come in all sorts of varieties, and we know this from the EP literature as well as all the CTs and MR imaging we've done. But keep an eye out for those flows in the back of the left atrium, and know that the right upper pulmonary vein is associated with the SVC as it comes from in the right chest. So those two structures should be seen together. The left upper pulmonary vein seen often in association with the left atrial appendage, so know that when you're looking at those two structures, what you're looking at. You can see how confusing this can be at times, but in this case, you can see a number of pulmonary veins returning to the left atrium. TE, obviously we use TE to look at pulmonary veins. I showed you an example of a common left upper pulmonary vein identification as well as a right upper pulmonary vein identification. And that image on the right is just adjacent to the SVC as the right upper pulmonary vein enters the left atrium. We're wrapping up here. So suprasternal notch imaging, it's not uncommon to see these images because these aren't the ones you're accustomed to evaluate. You're used to looking at the cardiac structures and maybe some less common known normal structures like the brachiocephalic vein can be viewed in your suprasternal notch, and you got to know that that's not fluid or a dissection flap or something like that. And I showed you a picture out of Gray's just to show you that's brachiocephalic vein just above that arch view from the suprasternal notch. And then in a moving color flow image, this is also a normal finding. This is not flow separation due to a dissection flap. This is a common Doppler phenomenon where flow is towards the probe, then away from the probe as it courses the arch or any tortuous vessel, and you see that flow separation. Note when it goes from blue to red, there's no transition where it aliased. This is actually just flow going across without any turbulence. This is just what's termed flow separation, and it's a normal finding from the suprasternal notch. It does not suggest there's a dissection flap in the aortic arch. You can even see part of it in the RPA as well on the color flow image in the center. So coming back, ASCEXAM Focus, I think we talked about all of these normal anatomic structures that you probably see all the time but may or may not realize they're normal. Persistent venous valves, Crista Terminalis, the coronary sinus, moderator bands, and then left heart structures like the pericardial recesses, the pulmonary veins, coronary arteries, the papillary muscles, suprasternal notch. So hopefully that gave you some good background on what a normal echo should be like and what the normal structures that you should be able to identify are. Thank you. Thank you.